A great day to everyone. Welcome, and I'll be lecturing today the colonic phase of integrated response to a meal and the metabolic functions of the liver as the second part of the lecture. This lecture is intended for my physiology class. The large intestine is composed of your cecum, the ascending colon, the transverse colon, the descending colon, the sigmoid colon, and the rectum. It is in the cecum that the appendix is located. This is the appendix. And there's a valve in between the terminal ileum and the cecum. It's called your ileocecal valve. So there are four functions of the primary functions of your large intestine. First is this used to digest, and absorb. Then it reabsorbs the remaining fluid that was used during the movement of the meal along the gastrointestinal tract, and then it stores the waste products of the meal until they can be conveniently eliminated from the body. In the large intestine, there is a unique biological ecosystem that consists of many trillions of our commensal bacteria called your colonic bacteria. And these bacteria can metabolize components of the meal that are not digested by the host enzymes and make their products available for the body via the process of fermentation. These colonic bacteria can also metabolize other endogenous substances like your bile acids and bilirubin, and they can detoxify xenobiotics or substances originating outside the body like the drugs. And this colonic bacteria protects the colonic epithelium from infection by invasive pathogens. The colon is both the recipient and the source of signals that allowed it to communicate with other gastrointestinal segments to optimally integrate function. Like when the stomach is filled with freshly masticated food, the presence of the meal triggers a long reflex arc that results in increased colonic motility, also known as your gastrocolic reflex, and it results eventually to the evacuation of the colonic contents to make way for the residues of the next meal. So there are signals that regulate colonic functions. So the colon is primarily regulated, but not exclusively, by neuronal pathways, wherein colonic motility is influenced by local reflexes that are generated by feeling of the lumen, thereby initiating distension and activation of your stretch receptors. These regulatory pathways exclusively involve the enteric nervous system, and it stimulates short bursts of chloride and fluid secretion, which are mediated by your 5-HT or your 5-hydroxytryptamine from the enteroendocrine cells and acetylcholine from the enteric secretomotor nerves. One example of the long reflex would be your gastrocolic reflex. In the gastrocolic reflex, it has both chemosensitive and mechanosensitive components, and in this reflex involves the release of the 5-HT and acetylcholine. The orthocolic reflex is activated on rising from bed and promotes the morning urge to defecate in some or most individuals. The colon is relatively poorly supplied with cells that release bioactive peptides and other regulatory factors. The exception would be the presence of the enterochromaffin cells. And these cells will release the 5-HT or the 5-hydroxytryptamine, and also this cell synthesizes peptide YY. The peptide YY is so named because it is a sequence that contains two adjacent tyrosine residues, wherein Y is the single letter code for amino acids. The peptide YY is synthesized by the enteroendocrine cells, which are located in the terminal ileum and the colon, and is released in response to lipid in the lumen. The functions of your peptide YY decreases gastric emptying and intestinal propulsive motility. So it lessens the transit time. It lengthens the transit time. And it also reduces the chloride. Thus, it also will decrease the fluid secretion by intestinal cells. Thereby, your peptide YY has been characterized as what they call the ileal brake, in that it is released if the nutrients, especially fat, are not absorbed by the time that the meal reaches the terminal ileum and the proximal part of the colon. By reducing the propulsion of the intestinal contents, in part by limiting their fluidity and distension-induced motility, the peptide YY provides more time for the meal to be retained in the small intestine, where its constituent nutrients can be digested and further absorbed. Colonic motility responses consistent with its primary function. The two predominant motility patterns of the large intestine are directed not to propulsion, again, not to propulsion, but rather to the mixing of the colonic contents and retarding their movement, thereby providing them with ample time in contact with the epithelium. So there are two distinct forms of colonic motility that was been identified. The first is the short duration contractions, which is designed to provide for mixing. These contractions originate in the circular muscle and are stationary pressure waves that persist for approximately 8 seconds on the average. The next would be the long duration contractions, and these are produced by the Taenia coli, which lasts for 20 to 60 seconds and may propagate over short distances. The propagation may involve orally as well as aborally, particularly in the more proximal segments of the colon. But these motility patterns are thought to originate largely in response to the local conditions like distensions. Thus, the small intestine transit times are relatively constant, and contents may be retained in the large intestine anywhere from hours to days without signifying dysfunction. The colonic mucosa is surrounded by continuous layers of circular muscle that when it contracts, it divides the colon into segments called your haustra. So this is a very good radiograph that shows prominent haustral patterns. Okay, so these are the haustral patterns. Okay, so there are also 3 non-overlapping bands of longitudinal muscles known as your Taenia coli. So there's a condition wherein a segment of the colon remains permanently contracted and can result to obstruction, and this condition is called your Hirschsprung's disease, otherwise known as your ganglionic megacolon, wherein there's mutation in the glial-derived neurotrophic factor and the endothelin 3, as well as their receptors. So the affected segment completely lacks the plexuses of the enteric nervous system and the associated ganglia. So the segment that is aganglionic remains contracted and the lumen occluded. So for the history of the Hirschsprung's disease, these usually are more common in childhood, wherein the child may present with a constipation with alternating diarrhea, the mechanism of which, when the proximal part of the aganglionic part of the colon will later on be filled with feces because the distal part is occluded because of the absence of the ganglia, so it remains closed. So the pressure builds up, and so as with the presence of the bacteria. So now the filling up will now present as constipation, so there will be no bowel movement, and can be discomfort to the patient, and you might even appreciate a mass on abdominal palpation. If the contents now, the bacterial content now, and the pressure will irritate the mucosa of that parts that is now filled with feces, it can initiate infection, a form of enteritis, thus producing more mucus, and later on will produce secretion of water, and thus the production or the development of diarrhea. So fluids now can a fluid like feces can now enter through can get through the obstruction and will manifest as diarrhea. Once the feces has been partially evacuated, the irritation may be resolved, and thus there will be again the period of constipation. So it will be on the history. You will be presented with the child with maybe abdominal distension that would be a palpable mass, okay, either on the left lower quadrant, or which is the most affected part of Hirschsprung's disease. And later on, the history will tell you that there is alternating constipation, then diarrhea, and then constipation again. So this slide will teach us what are the reasons to fart and not to defecate. So this is the anatomy of the rectum and the anal canal. For the colon terminates in the rectum. Okay, so this is now the rectum. Okay, which is joined to the colon in an acute angle called your rectosigmoid junction. The rectum lacks circular muscles, is surrounded only by longitudinal muscles. Okay, and with these ones, the muscular contraction can also form what we call your rectal valves. Okay. So the combination of these muscles, okay, because also the rectum may contain striated muscles and of course bisphosed muscles. So the combination of these muscles will account for the two key sphincters that control the evacuation of the solid waste and flatus from the body. And now, further looking downward, you can appreciate the internal anal sphincter and the external anal sphincter. So the internal anal sphincter is composed of a thickened band of circular muscle, while the external anal sphincter is made up of three different striated muscles, which are wrapped around the anal canal coming from the pelvic cavity. So the external anal sphincter are distinctive because they maintain the significant level of basal tone and can be contracted further either voluntarily or reflexively when the abdominal muscle pressure increases abruptly, like when you are lifting a heavy object. Now let's talk about the transport mechanism in the colon. And we have clinical cases regarding this topic. First would be your irritable bowel syndrome. It is the name given to a heterogeneous collection of disorders whose sufferers complain of diarrhea, constipation, all alternating pattern or both, often with accompanying pain and distension. Though the disorder's mechanism is not fully understood, but it may involve in part a condition of visceral hypersensitivity in which the individual perceives normal signals originating from the bowel, such as in response to distension, as painful. So most treatments for irritable bowel syndrome would be symptomatic relief, but still treating irritable bowel syndrome will still remain as a challenge because most often irritable bowel syndrome is refractory to therapy. Next would be your colon cancer. So colon cancer arises when the normal genetic controls on the rate of epithelium proliferation are subverted. Initially, this leads to growth of a polyp and eventually, if not removed, to an invasive tumor that may metastasize to the other parts of the body. Colon cancer can be subdivided according to the basic nature of the underlying molecular defect. Okay. First would include overexpression or of growth stimulatory factors or a mutation that prevents the cell from responding to factors that would normally be growth suppressive. Thus, mortality can be reduced by early detection and removal of the polyp with the malignant potential. Colonic epithelium turns over rapidly, so it can be protective because it can limit the accumulation of genetic damage that might otherwise be caused by the exposure to toxins in the lumen. But it may be of benefit, but still the rapid turnover also increases the risk for malignancy. The major role of the colonic epithelium is to absorb or secrete electrolytes and water rather than nutrients. So that's the major role of the colonic epithelium, to absorb or secrete electrolytes and water rather than nutrients. The colonic epithelium absorbs short-chain fatty acids salvage from the non-absorbable carbohydrates by the colonic bacteria. One short-chain fatty acid is your butyrate. Okay, it's a critical energy source for the colonocytes. A reduction in butyrate levels in the lumen may induce epithelial dysfunction. And this is a fact that colon receives around 2 liters of fluids each day and absorbs around 1.8, thus leaving around 200 ml of fluid to be lost in the stool. The fluid absorption by the colon is driven by 3 transport processes. First is the electroneutral sodium chloride absorption. Next would be the absorption of the short-chain fatty acids. And the third would be the absorption of sodium. Now, the figure on the right represents the absorption of the short-chain fatty acids in the colon. The short-chain fatty acid would include your acetate, your propionate, and the butyrate. These molecules are absorbed from the lumen and perhaps in the crypts in a sodium-dependent fashion, by a family of symporters related to the sodium glucose symporter. The small intestine is known as your sodium monocarboxylate transporters, or your SMCTs. In here, the uptake of the short-chain fatty acid is driven by the low intracellular sodium established by the basolateral sodium-potassium ATPase. So sodium will decrease because through the sodium-potassium ATPase, it pulls out sodium by bringing in potassium, thus creating a low sodium cell, and it will now drive the absorption of your short-chain fatty acid along with your sodium through your SMCT1 transporter. So these short-chain fatty acids are used for energy by the colonocyte. This slide represents the last process of your fluid absorption, which is the absorption of sodium. This is a major significant process of absorption. This transport process is predominantly localized to the distal part of the colon. It is driven by your epithelial sodium channel, or your ENaC, in response to the low sodium because of the excretion of sodium via your sodium-potassium ATPase. In this process, chloride and water will passively flow via the intercellular tight junction to maintain electrical neutrality. Thus, this mode of sodium absorption is the last line of defense to prevent excessive water loss. And it's noteworthy that fluid secretion in the colon is driven by chloride ion secretion, by the same mechanism driving fluid secretion in the intestine, and is subject to the same regulation. In some cases of constipation may reflect abnormalities in the epithelial transport, and constipation that results from abnormally slow motility can be treated by agents that stimulate chloride secretion. Okay. And excessive chloride secretion can be one mechanism that underlies the process of diarrhea. So for diarrheal diseases, it can be due to, generally, worldwide, it's due to inadequate access to clean water and food. Mostly, this type of diarrhea can be secondary to the infectious cause, or it can be secondary to not appropriately digested and absorbed food. In most diarrheal diseases, colonic sodium chloride and sodium absorption are downregulated at the same time that chloride secretion may be stimulated, thus further worsening fluid loss. The nutrient-linked sodium absorptor process typically remain intact. This provides the rationale. Okay? This is the rationale for the use of the oral rehydrating solutions, which are prepackaged mixture of salt and glucose. The uptake of sodium and glucose from this solution is mediated by your SGLT1, which drives water back into the body to balance osmotic pressure. Bacterial enzymes act on both endogenous and exogenous substrates, for they form secondary bile acids and they conjugate any bile acids that have escaped uptake in the terminal ileum so that they can be reabsorbed. They convert bilirubin into urobilinogen and salvage nutrients that are resistant to pancreatic and brush border hydrolysis, like the dietary fiber. And with this in mind, bacterial metabolism with the colonic microflora can also be exploited for pharmacological purposes. A drug targeted to the colon, for example, can be conjugated in such a way that it will become bioavailable only after it is acted on by the bacterial enzymes. Bacterial enzymes may also detoxify some dietary carcinogens, but equally they may generate toxic or carcinogenic compounds from dietary substrates. This table shows us the summary of the metabolic effects of the enteric bacteria. Okay. So we have your endogenous substrate like your urea, bilirubin, primary bile acids, conjugated bile acids, and exogenous substrate like the fiber and amino acids. So these are the enzymes that are utilized that are coming from the colonic bacteria. Like for urea, it uses urease and it produces ammonia, and the disposition would be passive absorption or excretion as ammonium. For bilirubin, the bacteria produces reductases and converts the bilirubin to urobilinogen and stercobilins, and it is excreted by passive reabsorption. For the primary bile acid, it is acted upon by dehydroxylases produced by the bacteria and converts it to secondary bile acids, and it is disposed by passive reabsorption. For conjugated bile acids, primary or secondary, it is degraded by deconjugases by the microflora, converting into deconjugated, converting to unconjugated bile acid, and it is goes to passive reabsorption. Then for exogenous substrates like your fiber will be acted upon by the glycosylated glycosidases produced by the bacteria to produce short-chain fatty acids, hydrogen, carbon dioxide, and methane. Okay, so these substances can be actively absorbed or excreted in the breath or flatus. So it's from the fiber that we produce much air. Okay, and for amino acids, like it will be acted on by decarboxylases and deaminases to produce your ammonia and bicarbonate, and these substances are reabsorbed or excreted as ammonia or ammonium. And the last would be, it's not just included in this table, would be the cysteine and methionine, which are acted upon by the bacterial sulfatases to produce hydrogen sulfide, the one that stinks. Okay? It is excreted in the flatus. Okay. Now let's talk about the deadly fart. Okay, so the deadly fart are actually intestinal gases produced from, usually from fibers. Okay, as I mentioned, okay, with that are processed and digested by the enteric bacteria by the glycosidases that they produce. Okay, so they produce hydrogen, carbon dioxide, and methane, and are excreted in the breath or flatus. So these are intestinal gases, and it is composed of large volumes of air swallowed, but the majority of this swallowed air are returns to the esophagus through the process of belching. So the production of intestinal gas would be secondary to fermentation, wherein the fermentation of the unabsorbed dietary components of a food, the microflora will generate large volumes of nitrogen, hydrogen, and carbon dioxide, and approximately 1 liter of these. Okay, non-odorous gases is excreted on a daily basis. So your nitrogen, hydrogen, and carbon dioxide are non-odorous, and 1 liter of these are often produced daily and are excreted. But some individuals may generate appreciable concentration of methane, okay, and also trace amounts of, maybe for some it is not trace amount of hydrogen sulfide, indole, and escatol, especially when they've ingested cysteine and methionine, which is acted upon by the sulfatases of the intestinal microflora to produce hydrogen sulfide. And these are the 3 substances that makes the fart deadly and odorous. Now let's proceed to the final stage of the journey, which is the expulsion of the indigestible residues from the body, the process known as defecation. The feces contain remnants of dead bacteria, dead and dying epithelial cells that has been desquamated from the lining of the intestine, biliary metabolites specifically targeted for excretion, like the conjugates of xenobiotics, and a small amount of water. In a healthy individual, the stool contains little, if any, useful nutrients. Okay. The presence of such nutrients in stool, particularly lipid, known as your steatorrhea, signifies maldigestion, malabsorption or both. Thus, fat in the stool is a sensitive marker of the small intestinal dysfunction because it is poorly used by the colonic microflora. But the loss of carbohydrates and protein in the stools can also be seen in underlying conditions that tends to worsen. Okay? So the process of defecation is controlled and requires coordinated action of the smooth and striated muscles in the rectum and anus. The expulsion of the stool from the body is controlled by the internal and external anal sphincter, which contribute approximately 70 to 80 and 20 to 30% of the anal tone at rest. The feeling of the rectum causes relaxation of the anal sphincter by the release of the following substances. Okay? The vasoactive intestinal polypeptide and the generation of nitric oxide. The relaxation of the inner sphincter permits the anal sampling mechanism, which can distinguish whether the rectal contents will be solid, liquid, or gas. So this is the key concept of the large intestine. Okay. So the final segment of the intestine through which the meal traverses is the large intestine, which is composed of the cecum, the colon, rectum, and anus. The primary role of the large intestine is to reclaim water used during the process of digestion and absorption, and to store the residues of the meal until defecation is socially convenient. Next would be colonic motility. Primarily serves to mix and delay the passage of the luminal contents other than during periodic large amplitude contraction that convey fecal material to the rectum. And third, the colon is highly active in transporting water and electrolytes, as well as product salvage from the undigested components of the meal by colonic bacteria. And the fourth would be that the colon maintains a lifelong mutually beneficial relationship with the vast bacterial ecosystem, which this ecosystem metabolizes endogenous substances, nutrients, drugs, and protects the host from infections with pathogen. And the last concept is that defecation involves involuntary and voluntary relaxation of muscle structures surrounding the anus and reflex pathway that control these structures. So that wraps up my lecture on the colon, and now we will proceed now to the transport and metabolic functions of the liver. So this is now the next second part will be the transport and metabolic functions of the liver. The anatomy of the liver with its relationship to the abdominal structures. So the liver is beneath, okay, the diaphragm, and it occupies the superior aspect of the abdominal cavity. It is usually found on the right, okay, upper quadrant in the general population, because I say normally found because there are also people, a small percentage of us can have it on the other side, those especially those with situs inversus totalis, okay, and the stomach is located on the left side under the liver, and it also can touch the part of the angle on the part of the ascending and transverse colon. So this is the blood supply of the liver, wherein it serves as a gatekeeper and a garbage disposal, because it receives its supply from majority of supply from the portal vein. from the intestine. Okay. So it serves as a gatekeeper by limiting the entry of toxic substances into the bloodstream and a garbage disposal system, for it extracts potentially toxic metabolic products produced elsewhere in the body and converts them to chemical forms that can be excreted. So the liver has an unusual blood supply because the majority of blood arriving from the liver is through the portal vein that drains from the spleen, the stomach, the pancreas, the small intestine, and the colon. Thus, the liver does not only receive nutrients but also potentially harmful substances. Depending on the efficiency with which these molecules are extracted, these substances by the hepatocytes, they are all subjected to what we call the first-pass metabolism. So the liver serves as the first site of the processing for most absorbed nutrients and also secretes bile acids, absorption of also AXA4, which will be used for the absorption of lipids from the diet. The liver is also a metabolic powerhouse, for it is critical for disposing a variety of metabolic waste products and synbiotics. And the liver stores and produces numerous substances like your glucose, amino acid, and plasma proteins. So the key functions of the liver, there are three areas. First, contributions to the whole body metabolism. It is very much involved in detoxification, and later would be the excretion of protein-bound or lipid-soluble waste products. So the liver contributed the metabolism of your carbohydrates, lipids, and proteins, and it plays an important role in the glucose metabolism, like the process of gluconeogenesis, okay? When the conversion of other sugars to glucose, when there is a need, when the body will be exposed to low sugar levels. The liver also stores glucose as glycogen at times of glucose excess. And releases stored glucose into the bloodstream as it is needed. So this is the process what we call the glucose buffer function of the liver. The hepatocytes may also participate in lipid metabolism because they are rich sources of metabolic enzyme engaged in fatty acid oxidation to supply energy for the other body functions. So as I stated, the liver metabolic functions of the liver would be for the metabolism of the carbohydrates, lipids, and proteins, and it's much involved in gluconeogenesis, wherein it stores glucose in times of excess as glycogen, and when glucose is needed, it now again transform glycogen to glucose in the process of gluconeogenesis, and it is what we call the glucose buffer function of the liver. So it's also involved in lipid metabolism, especially because the liver produces a lot of enzymes for fatty acid oxidation and converts products of carbohydrate metabolism to lipids. And also it is involved in protein metabolism because it synthesizes all non-essential amino acids, synthesizes almost all the proteins present except immunoglobulins, so that is the exception. It is a critical size for the disposal of ammonia. The liver and detoxification. Well, the liver is the largest gland for detoxification, because it serves as the gatekeeper and even a garbage disposal. The gatekeeper functions as a gatekeeper by limiting the entry of toxic substances into the bloodstream, and also serves as a garbage disposal by extracting potentially toxic metabolic products produced elsewhere in the body and converting them to chemicals that can be excreted. The liver receives not only absorb nutrients, but also potentially harmful absorbed molecules like your drugs and bacterial toxins. Depending on the efficacy with which these molecules are extracted by the hepatocytes, all are subjected to what we call the first pass metabolism, wherein little or none of the absorbed substance may make it into the systemic circulation. That's the reason why not all pharmaceutical agents can achieve therapeutic concentrations in the bloodstream if administered orally. So there are two levels in which it removes and metabolizes or detoxifies substances originating from the portal of circulation. First will be of physical. The blood arriving in the liver percolates among the cells of the macrophage lineage, which are called your Kupffer cells. And these Kupffer cells are phagocytic and are very important in removing particulate material from the portal blood, including the bacteria that may enter from the colon even at normal circumstances. The second level would be biochemical. The biochemical reaction has two classes. Okay? Phase 1, reactions, wherein it involves oxidation, hydroxylation, and other reaction catalyzed by the cytochrome P40 450 enzyme, and the phase 2 reactions that conjugate the resulting products with another molecule like glucuronic acid, the sulfate amino acid, or glutathione to promote the excretion. The products of this reaction are then excreted into the bile or returned to the bloodstream to ultimately be excreted by the kidneys. The role of the liver in the process of excretion. The liver excretes by the use of large water-soluble catabolites, and molecules are bound to plasma protein, including those that are lipophilic metabolites and xenobiotic steroid hormones and heavy metals. These substances can be potentially harmful if allowed to accumulate. Thus, they are excreted via the bile, and after bile they will be excreted into the intestine, ending in the feces. So this is the structural features of the liver and the biliary system. The hepatocytes, okay, these are the hepatocytes, are the major cell type in the liver, are arranged in anastomosing cords that form plates. Okay, later on that will form plates, around which large volume of blood circulates. The liver receives a high blood flow that is disproportionate to its mass, which ensures that hepatocytes receive high quantities of both your oxygen and nutrients. Hepatocytes receive more than 70% of their blood supply at the rest by the portal vein, rising to more than 90% in the postprandial period. So in here, we can see the portal triad, which is the branches of the portal vein. This one. And hepatic artery. This one is the hepatic artery, the portal vein, and the hepatic artery that are located at the periphery of the lobule. Okay. So this is what you call your portal triad. Okay. Together with the bile duct. Okay, so that is your portal triad. Thus, the blood from the portal vein and the hepatic artery percolates around the hepatocytes via the sinusoids. So these are the sinusoids, they percolate, okay, in the hepatocytes and through the sinusoids before they are drained to the central vein. This is a very beautiful diagram that shows us the interrelationship of the major cells in the liver. So we have your hepatocytes, and here you have your sinusoidal lumen, and so in here. In the sinusoidal lumen, in one part you have your phagocytes, which are your Kupffer cells with your endothelium, and in there you have your endothelium in there, and in the other part will be your stellate cells. This is your space of these, and you have your bile canaliculus with tight junctions. So what is the importance of this? So in cases of the infection of the liver, with certain viruses or ever exposure to toxic substances like alcohol, which kills the hepatocytes, it activates this hepatic stellate cells to produce fibrosis. So excessive amounts of collagen later on are produced by the stellate cells to produce the appearance of fibrosis. If the insult is chronic, it becomes an irreversible condition like your cirrhosis. So what happens if there is fibrosis? If there is fibrosis, the circulation of the liver, especially its sinusoids, are compressed by the fibrosis. The liver loses its ability to accommodate the increases in the blood flow that occur after a meal without a concomitant increase in pressure. Because of the fenestrations, albumin escapes from the circulation, and albumin-rich fluids will seep through the surface of the liver into the abdominal cavity, where it overwhelms the lymphatic drainage and producing now, with albumin on the peritoneal space, and albumin, of course, it's a protein, it will now draw on in more water. It will lead to the condition known as ascites, and it will be reflected in the considerable increase in the girth of many patients with liver disease. As pressure in the liver builds, new collateral blood vessels, now this is what we call the formation of collateral blood vessels, is just to attempt to circumvent the obstruction and reduce the portal hypertension. So in cases of portal hypertension, there will be new collateral formation, and it will lead now to your varices. Okay? This collateral formation will now produce varices in the esophagus, when these varices are all subjected to the high pressures, and these varices their walls tend to be thin and weak and are prone to rupture. So if the chronic fibrosis will be irreversible, it will now lead to this condition. So cirrhosis. So this is the cycle of the cirrhosis, or stages from a healthy liver. Later on, it will be subjected to chronic toxins, alcohol, and even drugs, or even obesity itself, leading now to fibrosis. If that fibrosis will be chronic enough and it becomes irreversible, then it leads to now to what we call your liver cirrhosis. So this figure represents the functional anatomy of the biliary system. And here you have your right and left hepatic ducts from the liver that will form your common hepatic duct, and there will be this junction, and it will now go to your cystic duct and to your gallbladder. So from your gallbladder, okay, it connects now to your common hepatic duct to form your common bile duct. Okay. So the gallbladder's function is to concentrate the bile, and also it the one that contracts whenever we will have a fatty meal. Okay, so the common bile duct will drain uh, to the duodenum, and it will be the release will be controlled by the sphincter of OD. So in the duodenum, before the sphincter, it is joined by the pancreatic duct. Thus, for the bile formation and secretion, bile is the excretory fluid of the liver, and bile is a micellar solution in which major solutes are your bile acids, phosphatidylcholine, and cholesterol in an approximately 10:3:1 ratio respectively. The secretion of these solutes drives the concomitant movement of water and electrolytes across the tight junctions that lie adjacent to the hepatocyte to form your canalicular bile. Then, majority of the bile flow is driven by the secretion of bile acid across the apical membrane of the hepatocytes via your ATPase transporter known as your bile salt export pump. Then, the composition of the resulting fluid can be modified further as it flows through the biliary ductules, resulting to your hepatic bile. Still further in storage, the gallbladder becomes your gallbladder bile. Now let's talk about bile synthesis. So bile acid are end product of cholesterol metabolism. So cholesterol, once taken up by the hepatocyte, which will be selectively metabolized by a series of enzymes that result in the formation of the bile acids. It can be either be primary or secondary. So cholesterol, when taken up by the hepatocyte, will be acted upon by a rate-limiting enzyme by addition of this hydroxyl group to the 7th position of the steroid nucleus plus this enzyme, the 7-alpha hydroxylase enzyme, that will convert cholesterol to chenodeoxycholic acid, which is a dihydroxybile acid. Later on, this will be further hydroxylated by C27 dehydroxylase to produce cholic acid, which is a trihydroxybile acid. Okay. Or your cholesterol will be acted upon by C27 to produce your cholic acid, which are all primary. Your chenodeoxycholic acid and your cholic acid are primary bile acids. And later on, these primary bile acids will be acted upon on the colonic lumen by bacterial enzymes to produce 3 secondary bile acids, your ursodeoxycholic acid and your litocholic acid, which are coming from your chenodeoxycholic acid, and your cholic acid will be converted by intestinal enzyme to the secondary bile acid, which is your deoxycholic acid. So these are your secondary bile acids, okay? And later on, there will be conjugation, later conjugation after biochemical modification of these bile acids. There will be conjugation with either your glycine or your taurine, which significantly decreases their pKa, and that will result to bile acid that are almost totally ionized at the pH prevailing in the small intestinal lumen, and thus cannot be passively traverse cell membrane. So this one, later on, once conjugated, cannot cannot traverse intestinal cell membranes. Now for the enterohepatic circulation of bile acids. So bile acids assist in the digestion and absorption of lipids by acting as detergents rather than enzymes, and thus a significant mass of these molecules is required to solubilize all dietary lipids. So with the means of the enterohepatic circulation, it means that after being secreted by the liver, it will be concentrated in the gallbladder and released to the intestinal lumen through the sphincter of Oddi. Later on, they will be deconjugated, and there will be passive reuptake of the deconjugated bile acids from the colon, and they will be reconjugated again in the intestine, and later on to be secreted again as bile. So as those that are spill over from the liver to the systemic circulation, they will return back to the liver to be conjugated, and later on synthesized, conjugated again, and will be secreted as bile. So in this way, we acquire a pool of circulating primary and secondary bile acids, and daily synthesis is then equal only to Manner fraction, approximately around 10% per day, or 200 to 400 milligrams. Thus escapes uptake and is lost in the stool. So in here. So with this enterohepatic circulation, there's an exception to this rule, which is your liptocolic acid, which is preferentially sulfated into the hepatocytes rather than being conjugated with glycine or taurine, as you can remember in the initials, the earlier slides. Thus, the majority of such conjugates are lost from the body after each meal because they are not substrates for your ASPT, thereby avoiding accumulation of a potentially toxic molecule. Now let's talk about gallstones. So this is a nice video clip regarding the formation and the problem with the presence of gallstone in the gallbladder. Okay, so your gallstones are precipitated bile constituents, which are predominantly of cholesterol and or calcium bilirubinate, which is a pigment stones. Okay, and the problem that they will cause is they may obstruct biliary flow from this part to somewhere down. Okay, so it will now manifest as signs of pain, poor tolerance of large fatty meals. Then later on, we'll have signs of retention of biliary constituents and ending up to liver injury. So in susceptible individuals, mechanisms that normally prevent nucleation of saturated bile are either defective or overcome, and small crystals form and grow into gallstones. Human bile is often supersaturated in terms of its cholesterol content, thus increasing the risk of stone formation, particularly during prolonged fasting. Gallstones are especially common in middle-aged women who are obese, particularly those who have born children for unknown reasons. So we were taught before in the risk for developing gallstone will be present in 3F. 3F, female, fat, and 40. So we were taught before of the increasing risk for developing gallstones with the 3F. So this slide tells us about the neurohumoral control of the gallbladder contraction and biliary secretion. So it tells us how the bile flows out from the gallbladder into the duodenum, from the gallbladder to the duodenum. So it all starts with the presence of food in the duodenum. The nutrients will in the duodenal wall will result to the release of your cholecystokinin via the bloodstream, or goes through your vagal afferent, okay, going to the dorsal vagal complex, which later on stimulates the vagal efferents. Okay, so the cholecystokinin on the bloodstream, along with the acetylcholine produced by the stimulation of the vagal efferents. Okay, these two hormones, your acetylcholine and cholecystokinin, now will cause the contraction of the smooth muscle on the gallbladder, thereby expelling the concentrated bile to the bile duct. Okay, on the simultaneously from the dorsal vagal complex, it will now release at the end two other hormones, your nitric oxide and your vasoactive peptide, that will tend to relax the muscles of the sphincter of Oddi in this part of the duodenum. Okay, when the muscle that serves as a valve, okay, or a gate, when the muscle contracts, it now releases its hold on the tube, thereby increasing its diameter to make way or accommodate the incoming bile. Thus, it will now be going to the duodenum. So it all reacts to the presence of food and nutrients in the duodenum. Hopefully that is clear to you regarding the neurohormonal control of the gallbladder contraction, and so as with the biliary secretion. Now let's talk about the bilirubin formation excretion by the liver. So before, let's talk about the production of your bilirubin. Okay, so 80% of bilirubin are actually coming from senescent RBC that will later be broken down to produce your heme and your globin, the hemoglobin of your RBC. So heme is very toxic. Okay, these are usually produced from the death of red cells, especially those that are senescent red blood cells. So this heme in the areas of your reticuloendothelial system, which also includes your Kupffer cells in your liver and also in the spleen. Okay, so the heme, this is the heme in the reticuloendothelial system. This is your reticuloendothelial system cells in your RES. Okay, the heme, with the action of your hemoxygenase, or with the chemical of NADPH plus O2, will tend to liberate iron from the heme, converting it to the green pigment called your biliverdin. And again, this biliverdin will be further reduced to produce your yellow pigment or your yellow bilirubin. Okay, and this bilirubin, most of this bilirubin will be bound to albumin and carried to the bloodstream. So this is very important, the levels of your albumin in your bloodstream. So those patients suffering from hypoalbuminemia for whatever causes, like nutrition or even problems with your excessive spillage of your albumin, like in your nephrotic syndrome. Okay, the bilirubin produced from senescent RBCs, which is 80% of all as the raw material for making bilirubin. Okay, so these are carried by albumin to the bloodstream to be carried to the liver for the process of conjugation. So in the heme will usually this type of production of bilirubin are usually coming from the senescent RBC from the heme. Others are coming from muscle cells and from the liver itself. Okay, so this type of bilirubin, which is now also called your unconjugated bilirubin, will tend to cross the blood-brain barrier. So especially in newborn, it attaches to the brainstem and causes kernicterus, which is that can result to death. Okay, staining of the basal ganglia. That's called your kernicterus. Okay, so your conjugated bilirubin, this one is not it is not water soluble, so that's why it's carried by albumin going towards, should be brought to the liver. But there are times that the heme production is so excessive that the liver is not able to conjugate it to a water soluble bilirubin. Okay, as in cases in the newborn, wherein the production of your UDP, glucuronidase transferase, is not yet okay. The amount is not enough, okay, to process the bilirubin coming deriving from the senescent RBCs. You can see the formation of jaundice. Okay, so it's quite common to form jaundice in the newborn period, but those jaundice should be later on. Those are what we call your physiologic jaundice and should resolve in time. One is through exposure to the light, because the presence of ultraviolet will tend to convert this bilirubin to lumibilirubin, which is a more water-soluble type of your bilirubins. So in the liver, okay, so the jaundice is just a manifestation of excessive bilirubin in the blood, and it stains the skin and even the conjunctiva and even the mucosa. So this unconjugated bilirubin will be conjugated in the liver, and this conjugated bilirubin will later on be transformed into bile, and this bile will be will flow to the small intestine, and some will also go to the kidneys. That's why in the small intestine, the bacteria there will tend to deconjugate, okay, this conjugated bilirubin, and this deconjugated bilirubin will produce your urobilinogen, which will again be reabsorbed, and what will later on be excreted will be with the two forms, your urobilin serum and your estercobilins, which will give color to the stools, greenish color to the stools. Okay, so in this process, in the conjugation of your bilirubin in the liver, there are some congenital defects or conditions that may produce excessive inability of the liver to conjugate such the bilirubin. Okay, so it's called your Crigler-Najjar syndrome, and there are two types, your type 1 and type 2. In type 1, there's mutation in the hepatocyte enzyme UGT. Thus, your type 1 will mean complete lack of this enzyme, so the liver will not be able to conjugate, okay, this type of bilirubin. Is the unconjugated, so there will be excessive amount of unconjugated bilirubin in the bloodstream. Thus, the risk for this crossing to the blood-brain barrier, and if it's in a newborn, will tend to stain basal ganglia and causing kernicterus. And the other one would be your type 2, which will tend to have a milder mutation, so there's a bit of conversion, so there's a bit of conjugation in the liver. Not all is lost. So this is a very nice figure, that's 3114, and it discusses on how the liver takes care of the ammonia. Ammonia is a small, neutral metabolite that arises from protein catabolism and bacterial activity and is highly membrane permeable. The liver is a critical contributor to the prevention of ammonia accumulation in the circulation. This is important because, like bilirubin, ammonia is toxic to the central nervous system. Thus, the liver will tend to eliminate ammonia from the body by converting it to urea via a series of reactions, enzymatic reactions known as your urea or Krebs-Henschel cycle. And take note, the liver is the only tissue in the body that can convert ammonia to urea. So ammonia is now enzymatically converted to your carbonyl phosphate, and it goes to the series of reaction. And when your arginine is hydrolyzed, it produces urea and ornithine, and the cycle goes on. So this is how the liver metabolizes and takes care and prevent accumulation of ammonia in the circulation. Let's talk about the ammonia in homeostasis in health. There are three sources of ammonia, wherein two are major. 50% will be coming from the colon, are produced in the colon by the bacterial ureases, and 40% are produced in the kidney, and a small amount, that's around 10%, is derived from the deamination of amino acids in the liver. So here in figure 31-15, which represents the ammonia homeostasis in health. So the excretion, majority of excretion of ammonia is noted with the use of your kidneys, and 25% are excreted via the alimentary tract. And for the handling of ammonia, 85% of these are handled in the liver, and 15% are handled in the systemic circulation. So there should be a balance of ammonia. And if the metabolic capacity of the liver is compromised acutely, thus it can result to coma and death. So in cases of chronic liver diseases or failure, the patient may experience a gradual decline in mental function, which is called your hepatic encephalopathy. Now, we go now to the clinical assessment of the liver function. So, in the liver function, these are the tests that we can request. So, the AST, or your aspartate aminotransferase, and your ALT, or your alanine aminotransferase. These two. So these are the tests that you will can request if you are considering or if you would like to assess levels of hepatic injury. For biliary tree injury, you can request for your alkaline phosphatase. For the damage to the cholangiocytes, you can request for your GGT. And so whenever you ask, this is a very common question, for these are the liver functions, are the functions that also are. So the above tests are tests for liver injuries, so injuries in a particular part of the liver. But for the function, you all know that the functions of the liver would be your conjugation and production in secretion. So for if you would like to assess the liver function test, when we ask for liver function test, then what we do would be to request for the bilirubin to assess its capacity to conjugate, albumin to capacity to produce albumin, and your prothrombin time for the clotting factors. And of course, it is also associated with the glucose metabolism and ammonia. So if you will be requesting for liver function test, you request for bilirubin, albumin, prothrombin, or your protein, and your glucose. But if you would like to assess for evidences of hepatic injury, you ask for your AST and ALT. For biliary tree injury, you ask for your alkaline phosphatase and your damage to your colonic glands. You can ask for your GGT. So the key concept for the vital functions of the liver will include your carbohydrate and lipid and protein metabolism and synthesis. Your liver is also associated or concerned with the synthesis of a majority of plasma protein, including albumin, and is responsible for the detoxification of unwanted substances and excretion of circulating substances that are lipid soluble. And these are carried in the bloodstream and are bound to albumin. So your liver function would be will be dependent, or are the real functions either the secretory or the production of a certain enzyme or a certain substance. Substances are excreted from the liver in bile, okay, and bile is stored in the gallbladder, and the liver is critical for disposing of certain substances that would be toxic, especially like in the though it's small, would be the excretion of your ammonia. So this, I think, is my last slide. Okay, so these are all taken from the my reference is the 6th edition of Byrne and Levy. So if you want to, please read on it. And for those who would like to go back again to my lecture, so it's posted in my YouTube channel. Okay, so you can please click subscribe and share. Have a great day.